Hi guys, my name is Jessica, and I'm going to be presenting a flashcard on pneumonia. So we're going to scroll down and we're going to start with the disease process. So pneumonia is considered a lower respiratory tract infection. Pneumonia may develop as a primary acute infection in the lung, or it may be secondary to another respiratory or systemic condition in which tissue resistance is reduced. As pneumonia is a condition primarily affecting the lungs, there are multiple types of pneumonia identified within the literature. Categories may be based on the causative agent, anatomic location of the infection, pathophysiological changes, or epidemiologic data. The causative agent may be a virus, bacterium, or fungus. Anatomic distributions of lesions may be diffuse and patchy throughout both lungs, or lobar, meaning consolidated to one lobe. In some pneumonias, such as viral pneumonias, pathophysiologic changes occur primarily in the interstitial tissue or alveolar septi. Epidemiological categories refer to nosocomial hospital-acquired pneumonia, which affects those with less resistance, the elderly, the debilitated, the malnourished, or the immunosuppressed. Community-acquired pneumonia may be viral or bacterial. It can affect healthy persons, for example, following influenza, as well as persons with underlying cardiovascular or respiratory disease. Aspiration pneumonia involves aspiration of vomitus, which is irritating to tissues or nasopharyngeal secretions. As we move on, we're going to go into the pathophysiology of some of the pneumonias identified within the textbook, such as lobar pneumonias. Pathophysiology is marked as inflammation of alveolar wall and leakage of cells, fibrin, and fluid into alveoli, causing consolidation, and the pleura may be inflamed. This specific type of pneumonia is usually caused by S. pneumoniae, or pneumococcus, and the infection is localized in one or more lobes. The first stage in its development is congestion, in which inflammation and vascular congestion develop in the alveolar wall, and exudate forms in the alveoli, which Van Meter and Hubert describe as significantly impacting oxygen diffusion. Next, neutrophils, RBCs, and fibrin accumulate in the alveolar exudate, forming a solid mass in the lobe called consolidation. The RBCs in the exudate produces the typical rusty sputum associated with lobar pneumonia. The next pneumonia we are going to talk about is bronchopneumonia. Pathophysiology is explained as inflammation and purulent exudate in alveoli, often arising from prior pooled secretions or irritation. It occurs as a diffuse pattern of infection in both lungs, more often in the lower lobes. One or several species of microorganisms may cause the infection, beginning in the bronchial mucosa and spreading into the local alveoli. The next type of pneumonia is called Legionnaire's disease. This is a pneumonia caused by a gram-negative bacterium, Legionella pneumophilia. This microbe thrives in warm, moist environments, such as air conditioning systems and spas. The microbe is difficult to detect clinically because it resides in pulmonary macrophages and requires a special culture medium to grow outside of the body. This is a less common type of pneumonia. Primary atypical pneumonia differs from the more typical forms of pneumonia in both the causative organism, which is often viral or mycoplasmal, and the pathophysiology, which involves interstitial inflammation, while also causing necrosis of bronchial epithelium. The most common causative organisms of atypical pneumonia are Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella species. Another type of pneumonia that is specific in this textbook is Pneumocystis carinii pneumonia. A type of atypical pneumonia occurs as an opportunistic infection and often fatal in patients with acquired immunodeficiency syndrome, or AIDS. This microbe was formerly classified as a protozoan, but now it is considered a fungus. This also appears to be inhaled and attaches to alveolar cells, causing necrosis and diffuse interstitial inflammation. We are then going to move on to risk factors and briefly state why it is a risk. Due to the fact that pneumonia is an infectious process, it is important to consider the most important individuals who would be at risk for these infections, such as, for most types of pneumonia, the elderly, immunosuppressed patients, the disabled, young children, and individuals with cardiovascular and/or respiratory disease because of their immune system places them at higher risk. However, certain types of pneumonia have their own risk factors, such as Legionnaire's disease. As we identified earlier, individuals that are in warm, moist environments with air conditioners and/or spas increase the risk for this microbe to grow. Pneumocystis carinii pneumonia, specific in individuals with AIDS, as this fungus targets the low immune system. And then we move on to nosocomial infection, which is hospital-acquired. This would be a high risk for patients who are admitted within the hospital setting, especially patients who are mechanically ventilated for a period of time. This would place them at high risk due to the introduction of bacteria into the respiratory tract while intubating them. As it is noted that respiratory infections are the most prevalent nosocomial infection observed in ICUs. Major signs and symptoms and state how they are occurring. Due to the various types of pneumonia, there are some differences with each category. However, the major signs and symptoms that are prominent throughout most types of pneumonia are symptoms can range from mild to serious and may include a cough with or without mucus, fever, chills, and trouble breathing. While Van Meter and Hubert established that there may also be changes in lung sounds varying from rales, crackles, or wheezing due to the exudate that is currently filling the lung fields. Diagnostic testing for pneumonia would be, we would like to obtain a CBC with DIFF to establish leukocytosis, CRP to establish inflammation within the body, a chest x-ray and/or a CAT scan to obtain imaging of the lungs and determine if there is exudate or fluid within the lung fields, as well as a sputum culture to determine specific type of microorganisms present and to establish what treatment we would then give. And then I also implemented some pictures for pneumonia. So this picture is of obviously a chest x-ray. And then this red outline right here is a consolidation or basically a patch of where the pneumonia is infecting the lung, and it would be the right middle lobe. So as you can see over here, there's less patchiness and less of this white area. And then we move on to this picture that I found. So this presents the nasopharyngeal colonization with the pneumococcus and invasion of the lower respiratory tract. So these are the microorganisms, they're inhaled and then they go down into the respiratory tract. Extrapulmonary dissemination of the pneumococcus with resultant bacteremia. This would be if it was a pneumonia that was caught too late and not treated quickly, leading to bacteremia, bacteria in the blood, and then moving on to it can invade the myocardium, as well as you can develop coronary artery thrombosis due to the bacteria, damaging the myocardium, and then myocardial dysfunction. And then these are my references. I hope you enjoy my presentation, and I look forward to hearing from you all. Thank you.